Dear colleagues, welcome everybody to the EASL studio session. This is a special edition acknowledging the last 2 intense days of the Liver Cancer Summit. My name is Tom Lüdde. I'm based in Düsseldorf in Germany. And it is really interesting times right now. We had 2 intense days talking about the new concepts in liver cancer, but also we had very interesting original data in the recent weeks and months. So today's session will be called Let's Talk About Immunotherapy and Liver Cancer, the experts' views and visions. And I'm very happy and honored that I have 2 of the world's leading experts in this topic here with me in the studio session. First of all, I'm very happy to welcome Bruno Zango, which I do not have really to introduce to anybody who's interested in this topic. He is the director of the liver unit and co-director of the HPB oncology area at Clínica Universidad de Navarra in Pamplona, Spain. Bruno, thanks a lot for joining this.
Thanks a lot for the invitation.
And also, we're very happy that Tim Greten has joined this session. Tim, you are senior investigator at the Thoracic and GI Malignancy Branch and co-director of NCI-CCR Liver Cancer Program. Great to have you here.
Thank you.
I would like to start with a brief question to both of you, just to get a bit loosened up here. Bruno, when was the first time that you were confronted with the concept of immunotherapy in cancer? Do you remember this? Because obviously you were one of the first who realized how important this will be.
That was too long ago, I would have to say. It was the first thing I did when I started in a lab, and that was back in 1986, was studying NK activity in patients with hepatocellular carcinoma. That was planned to be the matter of my doctoral thesis, then turned to be a different thing. But ever since then, I have been interested in immune response in liver cancer, long time ago.
Cool. Tim, we once worked together in Michael Mann's department some time ago. I remember you did your postdoc in that topic, tumor immunology, and we once met, and at that point you told me you were not really completely sure if this will blast in the future. Now the future kind of proved you right. So how did you get this idea that this would be important?
Yeah, it's correct. So I did my postdoc in immunotherapy in '95. I started this, and before I already did some immunology, but really the tumor immunology started in '95 in pancreatic cancer. And as you said, after my postdoc, I joined a group in Hanover under the leadership of Michael Mann, and I basically decided to do what I still do. I tried to find a niche, and so I thought, Hanover, as you all know, is a site of hepatology and transplant and lots of liver cases. So why not doing something that nobody else, other than Bruno, obviously, was thinking of is looking at immunotherapy in the context of HCC. So we started then and did our first observations, and to be honest, my best publications are still from that time.
Okay, cool. So guys, we have 30 minutes now to discuss here, and my task is really to give you like a platform to exchange your views and also maybe get a bit deeper in the things that are important to you, that you think you would like to share with the audience. The audience, dear colleagues, we have a chat function, I think. So if you think you want to comment to something here, or you have a question that you would like us to discuss, please use the chat. And those who know me and have my phone number can also, of course, send me an SMS or whatever. In the next 30 minutes, 25 to 30 minutes, we decided we will cover what we believe are some of the major questions right now, of course. And we will start with a brief sum up of the summit, of what we all think was a great meeting. And then we want to focus on the large phase 3 first-line trials that were coming out in the recent weeks and months, the InBrave trial, the Cosmic trial, the Himalaya trial, and Bruno is here with the latest info from Himalaya, being last author on the abstract. But then we want to also focus on what we all think was one of the major questions, that was really, what is the role of the underlying liver disease entity in response to liver cancer treatment with immunotherapy? I think there is a lot of information came in, great discussions, but still many, many open questions. Do you agree, guys?
Absolutely, yes. No
so, Bruno, why don't you start? I was really wondering now, after 2 days, seeing so many talks, you were very active there. What after these 2 days of Liver Cancer Summit, what is your perception? Where is liver cancer standing right now? What are the main topics?
On the one hand, I think it was a very active meeting, and there was activity over the whole spectrum of interests in liver cancer. There was a lot of translational data presented, good clinical data, and an important thing to me was we are no longer seeing cholangiocarcinoma as just a bystander there, and there is a lot of research activity going on in cholangiocarcinoma that will probably and hopefully soon translate into better treatment. And we are going to talk about immunotherapy. And one of the things that strikes me is that we've done a lot of advances in treating the sickest patients, which is important for them, of course, and it might be important for the rest of the patients who already have. But I think we still have to address what seems to me the most important problem which is why, after curing hepatitis C and addressing effectively hepatitis B, we are not probably going to see a deep decline in the incidence of HCC. And these are the expectations. And this is, I think, is a failure for us. We have to put a lot of our efforts there. NASH and carcinogenesis. I think this is a big topic to address.
Yeah, maybe we can discuss this a bit. Tim, I learned you're also very known for great basic science and translational science. I learned the term the valley of death between basic research and clinical trials. After these 2 days, do you think this valley of death is still there, or is somebody going through it now?
Well, I don't think there's a valley of death. I mean, this was a positive meeting and this is a positive time. Let's just face it. Immunotherapy works in liver cancer, period. And actually we're done. It works. It does work in cholangio. It does work in HCC. Now, I know everybody's going to say it's not going to be good enough. It's only whatever 0.4 months or whatever number you come up, and the hazard ratio is not high enough. But the fact is it works, and there's other diseases where it doesn't work. So that is very, very good. Now, obviously, that's very simplification. The question is, how does it work? When does it work? How can we make it better? And those are important questions. And what I think, yes, there is this difference between basic and translational and then clinical results. But don't forget, an area where you see clinical advances immediately attracts a lot of basic researchers. If you have an area where it doesn't work, it's very, very hard to convince somebody, to work on this topic. But if you say, as I just said, immunotherapy works, you will get a lot of interest, and you will raise a lot of interest in basic studies and translational studies. And yes, they will raise controversies. Some of them may explain what you see in patients. But, I don't think the time has ever been better, with the exception that we couldn't see each other.
I like very much one of the slides of your presentation, Tim, the one in which the mouse and the person are staring to one another, and your message there that different perspectives on one problem, but let's not forget that everything is about treating patients and trying to cure them. I think this is a very important message that, and in line what you have just said.
And I mean, also the immunotherapy success can be tracked back to experimental approaches in mice, you know, with colorectal cancer, transplanted to mice, treated with anti-CTLA-4, and it worked. So it's going back, maybe not from initial liver cancer days, but to experimental data, which can be a nice role model for the future trials. Bruno, may I just ask you again, because I also share your view that this is going beyond immunotherapy, you know, the question what the underlying liver diseases mean for liver cancer in general. You know, there were many discussions also now, you know, like is NASH, what is the cancer risk in NASH? Do these NASH patients do better? And basically, you know, like I remember the findings where it was said that NASH has a worse prognosis because these are older patients even than viral hepatitis. We detect them later than viral hepatitis now, and you were chairing a session also with great talks, learning that NASH patients do better in TKI treatment, for example. And so what's your view on this? And why does incidence not go down?
There are like two parts in your question. One is why is NASH such an important factor in developing liver cancer? Is it just because we know diabetes is it just a matter of persons living longer and so having a higher chance of developing the metabolic syndrome? Is it truly related to the metabolic syndrome epidemic? I think those are questions that from an epidemiological perspective have not been answered correctly. And while we do that, I think it's unquestionable that patients with the metabolic syndrome, with or without NASH, have an increased risk of liver cancer. And so what we have to try to elaborate a bit on is which patients are at higher risk, what can we do for them, how can we screen them, but even better, how can we prevent it? And I think there should be a better engagement between the research in NASH-related fibrosis and the evolution from the metabolic syndrome to cirrhosis, and the field of HCC and liver cancer in general.
Fully agree. I mean, Tim, I liked from Matthias Heikenwerder's presentation, he was mentioning this, putting this in, you know, have we really understood NASH? And can we all call these patients NASH? Is NASH a dirty disease because it's so heterogeneous? You know, now starting to look into spatial metabolomics, spatial inflammation, and so on. Will we learn maybe that we have to find more names to address carcinogenic potential?
Well, you know, NASH is a pathological diagnosis. That's all. It's only, you know, it's basically, you know, what you see, what the pathologist sees on the slide. And that's it. So, you know, I don't like this term NASH because, yes, you already mentioned this. You know, I think diabetes is way more important than anything else. You know, I think obesity, etc. And, you know, this we will study this, and you can, you know, look at the effects on whatever diets and specific diets on microbiome, etc. I personally, you know, I think there is many pathways and that you can study, etc. And yes, Matthias was right when he says, you know, there's different flavors, I believe, you know, is the term that he uses. You know, I would argue, you know, I've learned this once I, you know, moved over here to the US, you know, it completely depends on where you live. You know, if you go to Texas, they all eat potato chips and have a completely different fatty liver disease than you find somewhere else. And, you know, and that is not reflected in the term NASH, because that is just telling you there is actually an inflammation. In other words, immune cells in the liver. And at this on top, you find obviously, you know, specific changes in the architecture and fat.
So maybe we get back to this when we speak about the differences in the subgroups. Let's maybe turn to now the trial data again. You know, like what we have now. We have positive trials, the IMBRAVE trial. We have now the new Himalaya trial that is positive. We had the COSMIC data recently presented, who were negative. And we also had previously the Checkmate 459 study, who was showing a clear trend, but in the end failed statistical significance. So Bruno, maybe you can take the audience again there. And I would like to ask you one question to start with. Why were the two trials positive? What's your perception, and the other two not?
Yeah, so if we see the whole story, starting from monotherapies to combinations, what we can clearly see is, first, monotherapies of PD-1, PD-L1 inhibitors are able to produce very clinically relevant responses, leading to very prolonged survival. And in some cases, very prolonged stabilizations that are certainly not what you would expect from indolent tumors, but really translate an anti-tumor effect. Was that enough to change overall survival? Well, what the both 459 and the durvalumab versus sorafenib comparison in Himalaya tells us is that not that strong, but certainly you see there that one of the main characteristics of checkpoint inhibitors is the ability to increase long-term survivors because of these very deep, meaningful responses. And that signal was already there. By adding a second target, VEGF with atezolizumab and CTLA-4 with STRIDE, the combination that was tested in Himalaya, then overall survival changed. And there was a proven benefit in overall survival. But again, the long-term survivors were much increased than the overall survival. Again, highlighting the same peculiarity of immunotherapies with checkpoint inhibitors. I think what is most interesting to me is that we yet don't know very well why VEGF inhibition has changed the activity of PD-L1 inhibitors in that way, and why just a single priming dose of CTLA-4 blockade has changed the activity of durvalumab. Of course, we knew, and Tim and I did these phase 2 trials showing HCC is a CTLA-4 sensitive tumor, no doubt. You don't have to discuss that. But we all know that CTLA-4 inhibition is dose dependent as opposed to PD-1, PD-L1 inhibition. And one of the interesting things for debate is why is early inhibition of CTLA-4 so relevant? And is this also true for VEGF? Do you need continued VEGF to have this beneficial effect?
So
questions for discussion.
Can I ask, or Tim, please go ahead.
Yes, so yes, Bruno, you're right. But let me ask you something. If you really look at Himalaya and look at all the curves and include the third arm, which is durvalumab monotherapy. Now, can you explain to me why a high dose of tremelimumab results in a lower median survival? Okay, it's not statistically significant, etc. But if you look at the curves, you know what I mean. But you only see, the difference once you go beyond, the 12 months, really the 12 months or range.
Yeah, that's a very difficult question. I mean, the easy answer is, and it's absolutely true, is we cannot derive anything because the study was not powered to see a difference between others than the combination versus sorafenib or durvalumab versus sorafenib. So all we can discuss is just non-sustained by evidence. I am curious about the same thing. One of the potential things is that by increasing side effects, then patients may not be as exposed to CTLA-4 inhibition in that arm. And equally not exposed to PD-1, or in this case, PD-L1 inhibition. But this is an unsolved question. To me, what is very intriguing is why is CTLA-4 working so well in the initial phase of the response you're eliciting with the combination?
I think I wanted maybe to focus this question a bit, going to both of you, like, is there really evidence in these two trials, and specifically maybe in the IMbrave trial first, is there really evidence that anti-VEGF makes the tumor hot, makes immunotherapy more active, or is it not? Maybe we, like always, we have a subgroup of patients that respond to immunotherapy, but we have an agent that is acting anyway in hepatocellular carcinoma, the anti-VEGF TV, sorafenib, and so on, and we're just catching those that do not respond so nicely to immunotherapy, and by this we prolong the curve. I mean, can we dissect this experimentally, or can we see this effect in the trials? The difference?
So let me start maybe, because I'm not actually going to talk about the trials. It's really, Bruno knows this better, but yes, we know that the VEGF works, I mean, let's just face this. The HCC is not the only cancer. We have a lot of data from renal cancer, which is very similar in terms, I know it's not identical, but in terms of drugs that we use and combinations that we use, TKIs, combinations with the vascular targeting agents and checkpoint inhibitors. So we do know that there is a significant difference. So I think, it's hard to ignore that the anti-VEGF antibody has a significant impact. What the final mechanism is, and if this is only a specific group, I think, that's up in the air. And that is obviously, a problem we have with phase 3 studies, because, a phase 3 study only answers one question, which is the primary objective. And then everything else is guessing and giving us time to have a good time with our friends here and talk about it.
Yeah, absolutely right.
Want to add on this?
For the atezolizumab bevacizumab combination, the only thing we know to some extent is that it is clearly superior to atezolizumab monotherapy from the other trial, but we don't know what is exactly the contribution of bevacizumab because there was never a bevacizumab monotherapy arm there. And this is even more complicated if you look at the COSMIC trial data, because there you have VEGF inhibitor. Of course, it's a different one. You're targeting the tyrosine kinase. You're not targeting the receptor upstream. So, but there, the benefit in terms of was still premature, but likely will not be met. And so this brings us to the fact that maybe what we're seeing with the combination atezolizumab bevacizumab, is it an effect on HCC proliferation? Are we seeing an antigenic effect, or are we truly seeing immune response enhancement due to VEGF activity on stromal cells? Food for thought.
Yeah, so thanks for clearing this. So let's really now go to maybe the fundamental question, like, how about viral versus non-viral in these trials? And I think at the meeting, at the Liver Cancer Summit, I got great information was coming from clinical trials, discussions in the audience, but also from the basic science data, the experimental data. I think that's really what the summit is about, and there was a lot of inspiration to this. Now, we had the clear idea that from the IMbrave trial and also from COSMIC, that the non-virals do not act as well as the viral underlying disease HCCs. And now in the new trial, Himalaya trial, this is different in the subgroup analysis. So what can we do with subgroup analysis? Like, how valid are they? why are these two trials distinct in this fundamental question? And how, Tim, could you maybe provide even an experimental hypothesis why that is? So I've handed first to Bruno. I was stealing a question from Maria Reik that she was posting today, and she was mentioning that in Himalaya, the patients were stratified to the underlying liver disease, and we had more non-viral patients in Himalaya compared to them, whereas they were not stratified in IMbrave. Is that the reason, Bruno?
Well, first, let me say that I think subgroup analyses should be always put in the supplemental information in the papers. They should never be in the main text, because subgroup analyses are only valuable to see how robust the main question, as Tim said, clinical trials are defined to answer just one simple question. And so the subgroup analyses are there to see if you run different sub-analyses and all of them show a different result, then the results are not robust. If most of them go in the same direction, then the results are robust. This is how one should read. And I think this is a very good example. Different trials showing different outcomes in terms of subgroup analysis. Then you have the question of whether is non-viral has the same composition in terms of mix of patients. What is behind non-viral? How many are fat? How many are diabetic, etc. And to what extent what you're seeing there is differences in the etiology or in the way of life. And I also like one of Tim's thoughts in his presentation. We're seeing hepatitis B as an etiology by itself, and you run clinical trials, and then clinical trials, hepatitis B patients, they mostly come from Eastern countries. What about their diet? What about the style of life? What are we talking about? Then it's easy to translate that to NASH, but I fully agree that there are other things that we have to understand. But in the end, I don't think we should pay attention to subgroup analysis other than for raising questions.
Clear statement. Tim.
Yes.
There was your paper, there was Matthias' paper backing up the IMbrave data, right? And now the new trial comes and challenges it. What's your perception?
No, I think, that this goes back to the question, what are you trying to answer in a scientific question? And a clinical trial answers one specific scientific question, and that is described in the primary objective. If you perform animal or preclinical or basic studies, depending on how you want to define them, they are also designed so that you can answer a specific question. But remember, we design the experiment in a way to only answer one or two questions. We use inbred mice, they all eat the same diet, they eat all at the same time. But with fatty liver disease or non-viral, I mean, let's just be honest. Do I know if all my patients with HCC have fatty liver disease and they don't drink a little bit and they don't want to say this when they come to see me because the wife is there and, she doesn't, she always tells the patient not to drink a beer or a wine, or, there are, genetic factors, dietary factors, it is just not that straightforward. And none of these studies were ever designed to address this question. The question is interesting for the community and it raises a lot of speculation. But I think in the end, you really have to decide what are you answering with a specific, or what are you trying to figure out with a specific question?
I fully agree.
One question, may I ask a question to Tim? So we know that diet is important for fatty liver disease, whatever that speaks for. And we know that diet is also important for the microbiome, and you've been doing a lot of research in the microbiome and HCC. To what extent do you think we can understand fatty liver related outcomes without understanding the microbiome?
No, you can't. I mean, obviously they interfere with each other. There's no question. And this goes back to this point that I made earlier that, fatty liver disease is not fatty liver disease because it depends on what type of diet you eat. And depending on the diet you eat, we all know this. If you change your diet, your microbiome changes within 24 hours. It's a very rapid event. We do know of the liver-gut axis, there is a close interaction. So no, you cannot, you cannot separate one from the other. In a mouse model, yes. Again, there you have the advantage of looking at specific question and modeling different factors. And I think, when we first worked on this, for me, the most amazing result was actually a very different one. The most amazing result is really that the diet you have, depending on what you eat, it actually changes your immune environment in the liver. And I think, that's just very fundamental. Doesn't go about viral hepatitis. And by the way, for everybody in the audience, I just want to make sure you understand there is no viral hepatitis model in mice. So whenever you want to compare what we see in patients versus mice, it's not valid because we don't have a good model that mimics viral hepatitis in mice.
It's true. So the message would be from this round, it's too easy just to speak about viral and non-viral. It's just a subgroup analysis where it's just hypothesis generating. And we would have to, do we need a deeper phenotyping of the patients? Do we need to look at microbiome in the future? Or should we in the future, will there be a trial looking only into non-viral and into subgroups there? How can we address this question? Or is it irrelevant at this point and we just have one standard that we see and wait what's coming?
I don't think we will see this soon. And this reflects that the hypothesis is not too strong. So, because otherwise people will certainly jump into running a trial in a situation where outcomes may be obviously more favorable. I think we need a better understanding, and we need to learn from the data we have. And an important point is that we need to have access to the data that are generated in these very large trials. So is the independent research paying attention to those data that could certainly bring new ideas into the field? I know it's not easy, but it is something we should pursue.
Well, I'm fully with you, Bruno, in this, like it's so hard to, I mean, we could maybe find a biomarker when we apply, for example, artificial intelligence, but we do not get the samples from the big trials to look deeper. And we had this discussion also here at the meeting, but I personally think we should not accept this because in the end, it's the patient's property. It's the patient's right to also to ask for these samples and to get a better access, because we cannot get any better material than that from these large trials. But Tim, still, maybe we have to come already to an end. It's still great times right now. You were mentioning in the beginning that now doing basic research, translational research in liver cancer has not ever been more interesting. And we have so many interesting questions that we kind of touched already in this meeting and that we talked about the last 2 days.
Yeah, I couldn't agree more. The time is there. And I actually also want to take a little away from the pessimism with the data, because I think if you actually, and I'm definitely not an expert in this, so don't get me wrong here, but I see that there are changes in the way personal data is being handled. And if you look at this long term, I think there are actually, and I know there are movements towards this direction that actually, their personal data will actually be available for larger research studies.
100%.
Yeah. Good. So guys, time was running, in fact. It was flying. We're already at the end of this meeting. It was a great pleasure. I think we already summed up more or less the take-home message from our discussion. Last question, what can we expect this year? Bruno, what will be the next big data that you are waiting for, the LEAP-2 trial?
Yeah, certainly. The two pieces of information that I think we are eagerly awaiting is one, LEAP. So is pembrolizumab a similar situation to cabo-atezo, or is that a TKI related issue, the lack of OS benefit? And second, I think we are waiting for the first data coming from the intermediate stage, and there is a possibility that this will come during this year.
Cool. Tim, last question to you. What would you think will be the next real conceptual advance in immunotherapy of liver cancer? What's the next combination or?
Yes, I think I think it will be a non-T cell based approach. You know, the IMbrave data really suggests, you know, there must be something else which is independent. It may be correlated to T cells, but, you know, I think there are so many other immune cells in this environment, and I think this will be interesting. And then if you go back to the T cells, obviously, you know, adoptive cell therapy approaches are another option. Okay.
So thanks a lot to both of you. It's been 2 long days for you, but I think this was a really great session, really informative and entertaining. And thanks for joining. Thanks for everybody who stayed online. Please don't miss the next EASL Studio session, which will be hosted by Verena Keitel, one of the world-leading experts in cholestasis. She will have some very interesting speakers in this important topic, cholestatic liver diseases. And with this, thanks again to everybody, and enjoy the weekend, and of course, stay healthy.